So while Chris gets us going, I have the opportunity to introduce our next speakers. And I'm not going to kind of go through their bio because you have that information there, but we have Jessica and Vicki who have traveled all the way from Maine to be with us here in the warm, to them, the warm state of Georgia, as they will say. But I came across this article here a couple months back, and as I was reading, I was like, wow, I mean, this would be great information to be able to share across one of our platforms. And so as I read, I was like, I know somebody at Netric. I bet Netric, the Northeast Telehealth Resource Center, can get me in touch with these folks. And so we started emailing, and the next thing I know, I had a contact, and we were like, hey, we would love for you guys to come and share. But what was really kind of stood out to me was on their CHF readmits, they had hit 0 with 4 out of 9 months. And so if any of you are doing remote patient monitoring, from a health system standpoint, you'll understand that and kind of the magnitude of that. So we just wanted them to come and share and have the opportunity just to kind of present what it is they're doing and doing successfully, because I do feel like when it comes to remote patient monitoring, as I say all the time, there's a lot of money being left on the table, and I think there's a very large education gap. There still needs to be a lot of education around remote monitoring. So we're delighted that you all are here. I know you brought the cold weather with you, so it's cold for us in Georgia, but come on up. I know you guys are going to kind of tag team, and then I'll come up afterwards.
Good morning. Thank you for having us. It is very warm here. I never thought I would be here. I'm just a nurse from a town called Shawmut, which has 6 roads and a post office. So this, when they asked if I wanted to go to Atlanta, I said, like, Georgia? And they said, yeah, Jess. So this is the furthest I've ever flown. I am honored for this opportunity. I didn't think our program would become as big as it is. So a little bit about MaineGeneral. Vicki and I are employed through them. I've been there, it'll be 19 years in January for me. I started at the age of 10. So we're a nonprofit health system located in central Maine. And we do have, I think for our area, a lot of offerings. We have a regional cancer center. We offer primary care, specialty care. You can read those. But we have a good range of services. So our history with remote patient monitoring, I'm going to say probably about 15 years ago, we had a program we called the Turtle. I have no idea why. It wasn't green and it didn't look like a turtle. But what happened was the company that supported it had sunsetted. And so we chose, we had purchased all this equipment and then had no use for it. So in 2019, one of our boards had said, we really need to kind of ramp things up. And of course, this was pre-COVID. So one of the things they said is we're going to focus on restarting our remote patient monitoring program. And our number 1 diagnoses for readmissions at our hospital was congestive heart failure, and not far behind was COPD and pneumonia. So we got together as a small group, went through vendors, had them come up. We ultimately were very impressed with HRS, also known as Health Recovery Solutions. And so as you can see, this is the equipment we set up patients. And it was interesting today listening to the other speakers. I wondered, how do we relate to you guys? Very similar. We have patients that are on dirt roads that we have to meet them at the end of the driveway and walk down in our boots. These are folks out in Timbuktu. You're like, is that a house? So we can really relate to the same things you're seeing here. So when we set patients up, we provide the scale, a tablet like an iPad, a blood pressure machine, and a pulse ox. We like the system. It's really customizable, and we've changed it over it'll be 3 years. We went live in January. We've changed it up. We've provided videos in there. We've been able to load our own sodium education and program the conditions on what we see, and so it's not so cookie cutter. When we rolled out, we had a conversation in the past when we had remote monitoring. It lied in our home care department, but our leadership said, with home care pulling out so quickly these days and so many people not being eligible, we're going to miss a huge gap of patients. So we decided to let it lie in our community care team, and that's where it still lies today. Our focus is primarily from our own hospital, MaineGeneral, and patients with either a primary or secondary diagnosis of congestive heart failure. But we, like I said, we rolled out in January of 2020, and it wasn't far behind that the pandemic hit. So it kind of went from an organized chaos to, okay, we're going to enroll patients with COVID as well. Here's our breakdown of the last quarter. So I'm going to say August to about October by diagnoses that we have them programmed for. And as you can see, our top runner is always congestive heart failure. So we really focus heavily on that. COPD is not far behind. Hypertension, pneumonia, and at the bottom you see, again, this is just the last quarter, but we have a few patients on for COVID recovery as well. Breakdown by age. Again, same kind of time frame, that August to October is the dark blue, and then you can see little shades of light blue at the top of them. Those are patients that we newly enrolled over the last quarter. We have the eldest state in the nation, so it's not surprising to see we have people in their 90s using this on a daily basis without any trouble. But as you can see, our average age is around 60 to 70-year-old. When I started, I hired one nurse, and she did the monitoring daily. She went into the patients' homes and set them up. Today, I have 2 full-time nurses. Vicki's one of them. A part-time nurse, a medical assistant, and an office assistant, and we have about 215 patients on monitoring actively today. Our goal is to get to 300, and I'm gonna let Vicki take it from here. Do you want the clicker? I like the clicker.
Yeah. Good morning. I'm so pleased to be here this morning, and our hosts, they gave us a very nice evening and showed us all around, and the history of the place is beautiful. And I have to say, I was told, I pulled my shoes out of my bag today to wear. I bought some nice shoes to wear, and I ended up with my sneakers because I had 2 left feet, 2 different shoes. So that was the start to my morning. But I have to say, I've been with the program for about 2.5 years. I pulled into it about 6 months into it. And the program has had its growing pains and hiccups, and occasionally we still do overall. But we're very, very proud of the successes that we've had on congestive heart failure. The 3 of us that are involved in the program, the 3 nurses, the experience that we are home health experience, we have long-term care experience as well. So I think having the experience, the older nurses, we're able to do the triage that we have to do and call the patients. As you know, patient engagement is very important. And I think that's where we've gotten our patients to prevent the readmissions. It's something that we've been able to do exceptionally well. Our patients trust us. We are part of them. They know we're local, and I think that's a big thing. We're not calling from another country or another state even. We are local people that live in their town. Because we get the engagement is, well, call them, and before I even say hello, they say, yeah, I know my weight's up. I know I had that salt intake the other day, but having that lets us understand that they know why they're on the program. They understand that, yes, the salt that they had, that ham Italian or the pizza they had last night, is going to cause their blood pressure to go up. But we don't reprimand them. We say, yeah, that had a lot of salt in it, but hey, was it good? Okay, today, let's have the best day that we're going to have. You can go slide 2. Another thing that we have is we have a really good relationship with cardiology. We have some liaison nurses there that we're able to call them specifically, say, hey, I have a patient that their blood pressure's up today, or their weight's up 2.5, 3 pounds. They feel kind of puffy. They're short of breath. We will then fax the vitals to this nurse, who will give it to their cardiologist. They will contact the patient themselves. Hey, let's have your diuretic for 3 days, and they'll call check on it in a few days. So we get a call back from the nurse from cardiology to say, this is what's happening. So we'll call the patient the next day, how are you doing? And it prevents them from having to go into the emergency room or prevents them to having to go into the office to have that med change, which is huge. Another thing we look at our patients, we look at them holistically because they not only have congestive heart failure, they may have kidney issues. You're riding that fine line, your double-edged sword. Diuretics affect your kidneys, but you need the diuretics for the fluid, but if your kidneys aren't working, you're gonna have the fluid. So we have to watch that. We watch, their mental health issues. We also look at other issues. They may have hypertension. All of these things come into play with our patients. It's not only, I have a patient that's in congestive heart failure. They have other issues. They are the caregiver of their husband who's ill. They have grandchildren that they didn't expect that they're going to be raising. So all these issues we look at with this patient to help them with a congestive heart failure, to try to have them focus on themselves, but we also understand that when they're talking to us, they may be having a hard day. We'll have a 20-minute conversation just so they can unload on us. But that way we get that, they get that relationship so that they trust us, that they'll let us know what's going on. Some of the barriers that we come across are compliancy with medications. And that can be one, they don't want to take their medications that we have to talk to them about. They can't afford their medications. Or the one I really like is, hey, I have doctor's appointments, I'm not going to take my diuretic because I don't want to have to go to the bathroom all day. So that's always, they tell me that right off. I call them, yeah, I know my weight's up, but I had doctor's appointments. I don't want to be hitting every bathroom on my way. Well, that makes a whole lot of sense. Another thing is, again, as they've spoken of, is financial issues as well. Some of our patients have to get Meals on Wheels because they're not able to get food, go out to the grocery store to get food. And even though the Meals on Wheels foods are supposed to be salt-friendly, they're not salt-friendly enough. But we understand that that's all that they can have, so we try to work in other ways with them. Transportation to get medications, again, like I said. Another thing is we have surveys on the HRS thing, and a lot of it is, are you short of breath today? You are having any chest pain or anything, coughing. A lot of them won't answer the questions. And that we try to tell them, hey, this is what we need them for because it lets us know how you've been in the last 24 hours. If they're not answering the questions, they have all green, it shows up, we don't have to call them. We don't have to triage every patient. But then they'll go into the emergency room and say, I've had a cough for the last 3 days. Well, if you let us know to begin with. So we try to do a lot of education on this is the reason we have to do this. The reason you may be having the cough is because you're having the fluid, going on. We also do a lot of education on their salt intake, like I said, as well as, I lost it. Yeah, there are other things that are going on. Some of the technology challenges we have are Bluetooth connectivity. And again, the state of Maine is very, very rural. And even in some areas, they have poor cell phone signal. So that really affects. If they have internet, it's okay because they can connect to the internet, which is good as well. But portal transmission issues. We'll call them and say, I did my blood pressure, but it doesn't come through to us. So luckily our support team for HRS has been very good that we'll call them and they can remote into the tablet and fix the issues that are going on. It's amazing though how our patients are able to manage the equipment. Like she said, we have a lot of older people, 85 to 90-year-old patients, how well that they actually do with it. I had a patient that I went in, set her up, and I had to call her every single day. And I walked her through put the cuff on your arm, tighten it up, and all of that. And by the end of the week, she said, that wasn't so bad. at all. She was able to do it, and we have quite a few of our patients that are 90, 93, very smart people that are able to do it. But then again, we then have the ones that don't want to do anything at all. Let's see. We have a lot of successes though, and a lot of saves. One of my patients I was calling and speaking to, I called her because she said, I've been really tired in the survey. So I asked her, you know, how are you feeling? I notice your heart rate is on the low side. It's only in the 40s. She said, that's funny. My pacemaker is set at 60. Well, the light went off. Her battery was dead in her pacemaker. And she had told me that she had been scheduled at some point, like 2 months down the road, to have a battery changed. With our liaison with cardiology, I was able to contact cardiology, and they got her in the next week to get a new battery for that. And she felt a whole lot better after that. So that those liaisons that we have worked out very well. I also had a patient, a young person actually, he was only in his 40s, I believe. He had congestive heart failure. His weight had been up quite a bit, so we had very long conversations about salt intake. You know, I sent him information on it. We talked about it when he called back. He understood it. He started watching what he was eating. He started losing weight. His blood pressure went down. And he was so thankful for that, and that he was able to, you know, level off with his blood pressure, and he was able to follow his diet. Remote patient monitoring is exciting, and it's really the way of the future, as everybody spoke about. We communicate with our patients via text. Almost every single day we get texts, which is great, because we have patients that are deaf, so that's our only way of communicating with them. But we can do it, we can use it with someone who is deaf. Our tablets can be changed to different languages, so they can read the questions on them and they can see everything in. We have had two who were Arabic, so the tablet was turned to Arabic. They could read all the questions on them, which is amazing. They usually had someone in the household that could speak to us, but the patient themselves could understand it, which is really awesome. The video chat, as they've told, video conferencing, we've used it on occasion. We haven't delved into it deeply as of yet, but it's something that we're going to be doing, and it is really good because you get to see the face of your patient, because they really like to see who you're talking to. And a new device that we have not started using, but we have it, is called the Echo Duo. It is a device that we can listen to their heart rate, we can listen to their lungs, and we can do an EKG. So that's coming, that we'll be getting going, and that is going to be really, really good for our congestive heart failure, as well as our patients with COPD. Now, I know a lot of our patients are very reluctant to leave us. We call them and say, hey, you know, it's time to graduate. Do I really have to? Those patients, we have a program, it's an app for a smartphone, a mobile phone, that they can do the exact same thing with their own. They have their own blood pressure and they have a pulse ox. They can do their vitals, they can put it in the app, they can answer surveys that are on the app. We still get the information. So we can transition them off our equipment, sort of onto theirs, give them about a 30-day, window, and then we can transition them completely off. But it gives them that little safe way, because we have them, we're their contact. A lot of our patients live alone, a lot of our older patients, they live by themselves. They're 80, 90 years old, and they still live by themselves, which is awesome. But we're that contact with them. And we have conversations long. They'll ask us to call them every single day just to have that person to hear from them. Again, I said education is big that we do. Label reading, we teach them. We have zone sheets as well that we teach them about congestive heart failure with their zone sheets. What point are you in? Are you a red zone, yellow zone as well? Remote patient monitoring has had its challenges and its barriers, but the healthy outcomes of our patients really outweigh the difficulties that we encounter along the way. I'll let Jess finish up.
Swap over to data for the folks that like this stuff, not me, I like the workflows. But as you can see, I've circled our 0% readmissions for 4 out of 9 months. We've never seen it in the history of our data. So I looked back about 2 years of data, and right before we started monitoring, there was 1 month we hit a 50% CHF readmission rate. So it was definitely one of our biggest diagnoses. We're not a big hospital, so our denominators are not large, which is the second number. 15, 17, 26. So if you have 3 people that bounce back in, it really makes a significant difference. So we're very proud of those zeros, and even the lower numbers of 6 and 10. We're very honored for those. This is definitely key. The adherence, I think, is why we're so successful. And when we started the program, we've discovered what happens if people don't monitor. So quickly we started if they don't monitor by about 11 a.m., we're calling them. Maybe they forgot, whatever, something happened that morning, they ran out for an appointment, whatever it may be, or sometimes the equipment's not working. So they did it, but it just didn't come through. And I really think our outreaches are the key of this. You can see the far right is the HRS average, which is the company, that's what their customers tend to rate. And we significantly surpass this really since we've begun. 86% of our patients are doing their blood pressure every day. The glucose is hit or miss, and that's because we don't really focus heavily. We don't have many diabetics. But same with our pulse ox of 86% and our weight of 85. So we're very proud of the outreaches and the effects of that. Patient satisfaction, this was definitely a huge thing as well, and we were very concerned from the beginning, knowing that we had the eldest state in the nation. But to me, this is backwards, but I'm French. But 1 is best. I want it to be 5. So as you can see, we're getting scores of 1.45, 1.36, and we're happy to share these slides so you can actually read the questions. But overall, how they're rating the program, I think my favorite one is the telehealth program makes me feel supported by my healthcare team, and that's pretty good scoring as well. Vicki touched on some challenges. When we first started, we also have a home care company within our system, and it got very confusing. We were allowing the home care company to call the doctors and get orders and come back, and it was so clunky. The patients were getting calls from our nurses, from the PCP office, so we eliminated that after a short period, and now the nurses do all the monitoring, but the home care does have access to the program, so they can go in and see how their patients are doing before they go in or when they go in to help encourage the use of it. The other kind of hiccup we had in the beginning was lack of orders. People didn't know about it. We hadn't had remote monitoring in almost 20 years. So we had to get back out there and push it along and show people what it was. Another little challenge we had was refusals. And these are orders, again, coming from our hospital. We hit a peak in June, this past June, of 50%. So 1 in 2 patients were refusing monitoring. So I started to dive in and said, what's happening here? As you can see, we're down to about 32%. I think the biggest culprit, and again, we've done a lot of education across our board. Some of the docs weren't very happy, but Vicki created a beautiful program through our system called Workday, and a lot of our docs, we made them watch it too. But at least they knew what it was and could speak to it, because that made a difference. The other thing was kind of the verbiage around how our care managers in the hospital were introducing it. Instead of just saying, do you want remote monitoring when you go home? Like, hey, do you want to pay for another bill? Yeah, I'm not going to sign up. But instead, if they made it more like, your doctor's ordered this, it's very successful, there's a nurse on the other end of that. It was all in the presentation of how they were introducing that. Reimbursement, this is not a money-making program by any means, but it's definitely a savings. 1 CHF readmission within 30 days averages about a $15,000 cost to the hospital. So we knew if we would offset just a few of those, it was well worth the investment of the remote monitoring. Currently, we bill for the 2 CPT codes I have up there, 99453, and that's setting up the patient in their home, going over the equipment. We charge $232 for that visit. The second code, 99454, is the monthly monitoring, and patients have to monitor at least 16 out of those 30 days to be able to bill for that. The other two codes are more around chronic care management billing. Our compliance team had initially felt like we weren't able to bill for that it needed to come from a medical staff, a PA or an MD, but we've recently revisited that, and we're going to begin doing those charges as well. The program tracks all the time for us, so it's just crazy not to do those charges as well, because that's the work. You're really doing care management too. I have to share a patient story. Corinne, she's 95. She lives alone. This is her story. She said, I was set up with equipment after I was discharged from the hospital. It was so easy to use and the staff were excellent. If my blood pressure was quite high, the phone would ring within 5 minutes, and a nurse would ask me how I was feeling and if everything was okay. It was excellent. Every morning at 9 o'clock, I would take my vitals, and if the numbers weren't good, a nurse would call me. I would take them again before noon, and if the numbers were good, I'd be all set. I used the equipment for about 7 months. I would tell anyone to take advantage of this program because it's a really big benefit for me, and I felt as if someone was paying attention to me. It was almost like having a little person in my home. So she would always rant and rave about it, and so our marketing team reached out and said, do you want to share your story? She was happy to. She invited him in her home, take a picture, I'll share. She was happy. This is just one example. I get phone calls pretty regularly, and Vicki gets direct feedback. Patients are honored to use this equipment and find it very, very helpful too from the patient perspective. Our future. We definitely have an opportunity to use the Patient Connect app, which Vicki talked about, where they have their own equipment and still have access to the quizzes and the surveys and everything. We struggle as well with, there's a family caregiver app, so if a family member lives even out of state, then they could see mom, dad, grandma's, vital signs, and it also helps motivate them. Like, hey, grandma, I checked the app this morning, you haven't done your vital signs. So we do have an opportunity there to utilize that more for sure. And maybe some other conditions. Maybe we look at surgery, who knows where we're gonna go. This was just our initial focus. Another thing we have an opportunity for is a diuretic protocol. We had a paramedicine program up in Maine for a while too, and now we have a very big shortage of paramedics, and so we've lost that program. Hopefully in the near future we'll get that back, and then we're able to draw the labs to support the diuretic protocol and even give the IV meds while people are at home, and then they don't even need to come into the office or anything to be managed. Lastly, I left our contacts on here. So Vicki and my direct line and our emails are on here. Any questions?
So if you have questions, if you'll just lift your hand, I'll be more than happy to bring you the microphone, okay? So we'll get my steps in.
Good morning. Thank you both. Excellent presentation. I'm Natalie Rogers with Each State Health Plan, and I'll be interested in learning more about your model as it relates to medication adherence that you spoke of for those members or patients post-discharge, and how do we loop in, or what is your model for looping in pharmacy services to ensure where there's adjustments necessary for medication regimens, that is done in a seamless manner, specifically taking into consideration perhaps the distance of the most local pharmacy to your patient community. I'd be interested in learning more about that.
Sure. We have a couple local small pharmacies that actually will deliver to patients' homes. So that's a huge advantage for us. It's not a contract or an agreement or anything, but they will actually fill patients' Medisets on a 7-day basis and deliver them to their homes. So that's a huge opportunity. As far as the medication reminder, when we first started and we were very small, we used to put patients every single medication in, and it would pop up at like 8 o'clock, and it would say, Lasix, 40 milligrams, metoprolol. But we found it was very time consuming to load every medication for every patient. We just didn't have that manpower. So we set it just as a time, 8 a.m., and we asked the patient. They might not get out of bed and want to do, meds or anything till 10. but we'll set a reminder at 10 and it just says AM meds. So to them, it's like, I'll take the AM slot. And we can do that for afternoon and evening as well.
Thank you.
Of course.
Dr. Sullivan. Hey, wonderful talk, thank you. I have two questions. The first question was, when you provide a telemonitoring kit, is that a kit that you're providing them out of your operation, your organization? Second, what seems to be a real plus is that your responsiveness, the amount of communications you put in between you and the patient seems to be a real underlying factor in your success. I was wondering maybe if you could address that a little bit, because it seems like that is what creates a relationship and therefore provides a positive sort of response from your patients.
Yes. The unit, we have purchased about 200 of them, so we own them now. The rest of them we lease. So we send them back to a warehouse in New Jersey where they test them and clean them, and then when we want 10 or 20 on hand, we request them and we leave them in our office. We didn't have the capacity to hold 300 units, so that seemed to be the best system for us. As far as the relationship piece, I think that's definitely a key as well. Vicki and the other full-time nurse, when a new patient starts on monitoring, they'll just call and introduce themselves. They'll call the next day or a couple days in and say, I'm Vicki, I'm the person on the other end here receiving your data. Here's my direct line if you want to call me. One of the questions every day they're asked is, would you like a nurse call today? But like Vicki alluded to, they have such good relationships where people will just say, yep, I knew you were going to call because I had ham. And I think that's the key, because they're comfortable and they're not like, I'm not going to answer the phone, I'm not going to do my they know they're going to get on the scale, they're going to gain a couple pounds, but Vicki's going to help troubleshoot through that and say, it's been a couple days now, so we're going to call your doctor and maybe make a change to your medication. But the relationships are key, not just with the patients, but also with our medical staff. They have a lot of trust in the nurses to say, he sounds pretty winded on the phone, so his weight's up and I think we've got some fluid on board.
Any other questions? All right. Orlando Hill.
Hi, good morning. My name is Desmond. I'm with Orlando Health. Would you mind going back a slide so I could just get your contact information?
Oh, of course. That's the easiest question I've answered.
Thank you. We're looking to expand our RPM program at Orlando Health, and we recently did a call with HRS, so I would love to touch base with y'all to just get your info.
Absolutely, happy to.
All right, thank you.
And we will post all of these presentations, and so we'll have those all available for you all. We'll email everyone once the slides are up.
I'm Katie Dolan. I am the Virtual Health Program Manager here at Atrium Health Madison Hospital System here in Macon. You mentioned at the very beginning of your presentation that when you restarted the program, you were embedded in your care team.
Yes.
Can you talk a little bit about what the structure of that might look like? Is the care team, is it much bigger than you? Are y'all, kind of how do you fit into that group?
We have a community care team. There's about 10 in the state of Maine. That department lied within my team, which has now grown significantly. Initially, that was just the department I led. And we have a contract with about 30 or 40 practices within the area. We're in an ACO. And so initially when we went back and forth, we felt like our two options were home care again, which was so limited to the time of period patients could be monitored, and or being homebound and all those things in between. So we said, let's open that a little bit more and go with our community care team. We've now opened it beyond those providers. The only kind of time we say no is if they're open to another Medicare certified home care agency, because then it gets challenging. If it's our equipment but they're providing the care, we don't have an agreement to work with them. But it has grown outside of our network, where we've had one of our bigger competitors will call and say, tell me about your remote monitoring, can I order that? And we're like, yep, as long as they don't have home care. So we're building relationships even outside of our accountable care organization.
Hi, I'm Jalen. I'm actually a medical student. I have a particular interest in opioids and pain management. I think this is really interesting and like towards that regard. You had mentioned kind of expanding maybe into the surgery, like maybe post-op recovery period. As far as your surveys go, do you guys do any behavioral health screening within those like surveys that you're asking patients on a daily basis? And do you have like a behavioral health referral portion to that? As well as, have you guys encountered any, I guess, pain management concerns like in your continuous monitoring with your patients?
It's a great point. We don't currently screen through this method for behavioral health. We do have other social determinants of health that we screen at our practices as a rule. And we have supports within our primary care. So we haven't focused heavily on behavioral health. As Vicki said, though, people are on monitoring for one thing, but have underlying mental health issues. We have some younger patients that, one young lady's in her 20s that is on for congestive heart failure, but has some substance use issues as well. So I think they overlap, but we don't focus heavily on it. We have a separate telehealth program with virtual visits that we're building upon because of the need for mental health, but not so much on our remote monitoring piece.
So one question here, have you guys had the opportunity, or have you, up to this point, have y'all really kind of dove into the numbers from a monetary standpoint? You know, of course, I think what you're doing.
I know.
Yeah.
I don't like data, I said that.
So I know what you're doing supports, actually, you know, even what Dr. Sumner was talking about, when you know, it's the patient care that matters. And I think this is where so many people really miss out, because you do have the opportunity to build some relationship with patients. But as we've said for a long time too, there's a lot of people are leaving money on the table. And of course, it's not just about the money, but the money is there, and that's been proven over and over again. So there's so many people who are not doing RPM or remote patient monitoring, and now it's RTM, and now you have CCM, and you've got all these codes. But if you're not doing that at this point, there is a lot of money that's being left on the table that, whether you're primary care or you're a small health system, or a large health system, I mean, it is there. I think the patient care, of course, is most important, but, for those financial people in the room, who think about the numbers and the bottom line, that is there, and that's been proven time and time again. So,
Yep. That's a good point. We should dive into, how many CHF readmissions did we have just for one calendar year, and knowing that we potentially offset those could give us at least some sort of monetary piece.
Yeah, so your speaking request numbers are probably quadruple at that point, if you start showing your all the CIOs and CFOs, all those people would then want you coming in to speak for them. So, all right, so no more questions before we turn the mic over to Ms. Rena Brewer. Let's give these ladies a hand.